Thank you for taking the time to view this presentation, a walk through the Family Care IRIS 2.0 concept paper. This presentation has been prepared by the Wisconsin Disability Association, and it's in response to the concept paper that was submitted by DHS to the Joint Committee on Finance on March 31st, 2016. If you'd like to download a copy of the actual concept paper, you can do so at the Family Care IRIS 2.0 website. Simply Google it and it'll take you right to the DHS website for this, and from there you can download a copy of the actual concept paper. This will just be a quick walk right through that concept paper as it's presented. In the executive summary, it really outlines some of the main conceptual changes to the proposed Family Care IRIS 2.0 program. And really the two biggest ones that might be of most concern to people with disabilities and advocates are the fact that the new family care program will include not just the long-term care services that are in the current family care program, but also the behavioral, acute, and primary health care services that most people now receive from the forward card. That's a pretty big transition. The other major transition is that all of the services that one receives in IRIS will no longer be offered through a program outside of family care. They will be incorporated into the family care program. So the new IRIS family care and IRIS 2.0 will be extended to all 72 counties. And really this is an effort to kind of control some of the expenditure growth that's resulting from demographics, particularly a very aging population, and the fortunate fact that people with disabilities are living much longer. The new program will have the same target groups as the current family care and IRIS programs. That would be adults with physical disabilities, developmental disabilities, and frail elderlies. It'll be offered within family care. A continuum of self-direction will be offered. There'll be at least there'll be 3 zones around the state. Right now there are, I think, about 10 or 11 family care zones. So it'll just be 3 new zones around the state, and each of those zones will have at least 3 integrated health agencies, also known as IHAs. And the Aging and Disability Resource Centers will continue to provide the good services that they do now. There'll be continuous open enrollment in the new program, which means people can switch between IHAs, and maybe whether they want to self-direct or don't want to self-direct, they can switch at any point. And people that are eligible for both Medicaid and Medicare, dual eligibles, can choose to obtain their benefits through fee-for-service Medicare. We do have some concerns about the scenarios presented in the executive summary. There is mention, and this has been around for a long time, that elderly people and people with disabilities make up just 20% of the Medicaid population, but they make up 40% of the costs of the Medicaid budget. And the response to that is, and how is this a surprise? It's been the same for decades. In general, people with disabilities, especially those with developmental disabilities that have tend to have complex needs and frail elderlies, it costs more to serve their needs than it does many other Medicaid enrollees, especially those who are only screened for eligibility based on financial criteria rather than both financial and functional screen criteria. Family Care 2.0, it really is going to seek to coordinate both long-term care services and behavioral acute and primary health care needs. That's a concern to us. We hope it can happen. We hope it will happen. But currently, the MCOs that operate under family care, they have a lot of expertise in coordinating long-term care services, but pretty limited expertise, with some exceptions, of coordinating behavioral acute and primary health care services. On the other hand, the entities that might come in from the state that could serve as IHAs, they likely have the opposite. A lot of experience in coordinating behavioral acute and primary health care services for enrollees, kind of the medical model, but limited experience in coordinating long-term care services. And really, for this new version of family care and IRIS 2.0 to be successful, any IHA is going to have all of that expertise under one roof. And those entities just don't exist at this point. Doesn't mean they can't exist, and hopefully they will, but it'll be a daunting but not impossible challenge to develop that expertise. Currently, family care and IRIS combined serve more than 55,000 adults in Wisconsin. And those programs are available in 64 of Wisconsin's 72 counties. Rock County will be starting the current version of Family Care and IRIS in July of this year. Eligible people waiting for services in the 8 counties, there's a substantial number of people, but those waiting lists will be eliminated once Family Care and IRIS 2.0 is fully implemented across the state. You can see that some counties have significant challenges related to people on the waiting list. These are eligible people, eligible for the services but not receiving them. And really the total number of people on the waiting list in these 8 counties is more than the total number of the people on the waiting list in all of the other 64 counties combined. We're pleased that DHS have provided many opportunities to learn about the proposed changes and to provide input. There's been several hearings held throughout the state. A good source for the updated information is the Family Care IRIS 2.0 webpage, and there's the address for that. Ongoing consumer and stakeholder engagement, this is one of the most critical components to ensure that the proposed changes are successful. The current versions of Family Care and IRIS, they became very effective programs due to ongoing stakeholder engagement and input. Now the new IHAs in the proposed Family Care IRIS 2.0, they'll be required to have consumer advisory councils as well as provider advisory councils. These are very good, especially when kind of looking at issues related to specific IHAs. And for the first year, DHS will conduct quarterly listening sessions in each of the 3 Family Care IRIS 2.0 zones. However, to make sure that the overall programs, both Family Care and IRIS 2.0 are effective, really DHS is going to have to take the lead in ensuring that there is ongoing stakeholder engagement opportunities as long as the programs operate. Really it's DHS rather than each of the IHAs that should be the portal through which stakeholders can provide the general input about Family Care and IRIS 2.0. The proposed new programs have the same guiding principles as the current Family Care and IRIS programs. The range of the long-term care benefits will be unchanged. The financial and functional eligibility criteria will be unchanged, and all enrollees will still have access to independent external ombudsman services. In terms of the design of the program, this is one of the big differences, is that basically IRIS as a separate program outside of Family Care goes away. It doesn't go away, it's actually incorporated into Family Care. For long-term care services, people will be able to choose to self-direct all, some, or none of their services. The IHAs must offer all long-term care services currently provided by Family Care, and they must offer most services that are currently provided through fee-for-service Medicaid, what people now get off of the forward card. We're a little bit worried about that. We'd like more clarification on exactly what most means. And people eligible for both Medicaid and Medicare can choose to receive benefits through Medicare fee-for-service or through Medicare Advantage program. If a member in the new program wishes to self-direct long-term care services, the IHA must provide a choice of at least 2 IRIS specialists, one of whom has to be independent of the IHA, actually not an employee of the IHA. If a member that self-directs feels that their budget isn't enough for their support plan, there's actions they can take, basically an appeal process both internal to the IHA, and they can actually file that all the way. They can actually approach the ombudsman or even go through DHS. And if a member chooses to begin or end self-direction of services or even make some changes, they may not be required to return to the ADRC to initiate changes. Self-direction will not be applicable to primary acute and behavioral health services. The members will still have choices of provider networks for those services through a choice of the 3 IHAs in each of the zones. But working with the care coordinators, members can select the appropriate approved providers of the primary acute and behavioral health services that are within their chosen network available through the IHA. Family Care Partnership is a program that's been around for quite a number of years. It's an integrated Medicare and Medicaid program that provides comprehensive services, kind of in the model of the proposed Family Care IRIS 2.0 model. But right now they're using that. Currently 3,000 people, mainly people with adults with physical or developmental disabilities and a frail elderly, same target group, they receive those services through Family Care Partnership. It's currently available in 14 counties, and DHS will continue this program and work to expand it to more counties. The integrated health agencies, they will be the entities that replace the current family care MCOs. They'll be licensed as insurers. Providers can negotiate and have contracts with more than one IHA, and it's DHS that will select all of the IHAs for each zone. And an IHA can operate in more than one zone. And we just discussed those zones. These are the family care regions that will be available. Right now, as I mentioned, there are about 10 regions around the state. We'll be going down to 3 in the new Family Care IRIS 2.0 program. The regions are really, they're not just drawn up on a map. They're based on, financial, all kinds of population, a bunch of actuarial data. An IHA must serve all the counties within a zone for which it's selected. An IHA can contract with providers outside of their zone, which is good for people that might end up living on the borders of some of the family care zones. And each zone must have at least 3 IHAs. Could have more, but must have 3. And the IHAs can operate in more than one zone, as I mentioned. The remaining 7 non-family care counties will transition to the new Family Care IRIS 2.0 when it's implemented in the zone in which they are located. All of the provider networks of each of the IHAs will need to be certified by DHS on an annual basis, just to make sure that the provider networks can meet the needs of the people in those zones. And this could be an opportunity to advocate for adequate reimbursement rates for direct care staff, a problem that we've had for years and years and years and only seems to be getting worse. There'll be continuous open enrollment in the new Family Care IRIS 2.0 program. So that's kind of based on the fact that in the current programs, there's been little demand to switch programs, either to move from family care to IRIS or even within family care from one MCO to another. That open enrollment will really provide an incentive for the IHAs to provide good services to their enrollees, because those enrollees could always go to another IHA at any time. And when Family Care IRIS 2.0 is first implemented, the current Family Care and IRIS members right now, the enrollees, will have the opportunity to select an appropriate IHA with the assistance of the ADRC staff. It's not going to be a matter where a switch is flipped and everybody who's currently in Family Care IRIS is assigned an IHA. No, from the very start, people will have the ability to select their IHA. The Aging and Disability Resource Centers will continue to perform the functional eligibility screen. They'll assist individuals in choosing an IHA or perhaps go into partnership. They'll help people determine if they want to self-direct any services, and for those that do want to self-direct services, the ADRCs will help them in selecting an IRIS specialist, either someone employed by the IHA or someone outside of the IHA. In terms of the payments that will be made to the IHAs, they'll be very similar to how payments are made to the current family care MCOs. Based on actuarial analysis, includes many factors, and the capitation rates will be set annually, as they just are now for family care. In terms of ensuring quality, as with the current Family Care and IRIS programs, DHS will focus on consumer outcomes, consumer satisfaction, and contract compliance. So if any IHA does not live up to what they should be in any of those areas, DHS will have the ability to impose some financial penalties. There'll be some special considerations for our tribes because really they're in the best position in order to be culturally sensitive to provide services that are culturally sensitive to their members. There are a few entities outside of the tribes themselves that are in a good position to do this. So based on that, the tribes will be able to continue to be service providers, contracted service providers with the IHAs. So next steps. Now that this paper has been submitted to Joint Finance must take action on the concept paper with either an up or down vote. There's no room to offer amendments. It's either you support the concept paper or you don't. Assuming the concept paper will be approved, once that happens, then DHS can really begin work on the formal waiver to submit to CMS, the federal agency that approves waiver requests submitted by states. When the draft waiver application is ready, DHS will make it public and provide a 60-day comment period and also an additional 30-day public comment period for tribal members. That's going to be a good opportunity to talk about what are the good things that you see, what are the bad things, and how can we change it to make it more effective to meet the proposed goals. DHS will then make the appropriate changes based on public comments and then submit the waiver to CMS. Now it's a give and take process, that approval process. CMS will likely ask questions, may seek some clarifications, and or suggest modifications. The final approval from CMS might take longer than expected and normal due to the level of staff turnover that will happen at federal agencies related to the impending change in administration, where no matter what, we're going to have a new president. So once DHS receives approval from CMS, DHS will issue the request for proposals to select the IHAs. And once the IHAs are selected, going through that process, Family Care IRIS 2.0 will then be implemented through a phasing in process, similar to what happened with the current version of Family Care and IRIS. It's not just a flick of a switch and a whole zone transitions to the new program right away. It'll be phased in. So what can we do? Certainly, what you're doing now is a great first step. Read and share information on the Family Care IRIS 2.0 concept paper and urge others to do the same. Please consider sharing this presentation with others. Share any concerns you have right now with your state legislators, because even if they're not on the Joint Committee on Finance, they can share their concerns with members of the Joint Committee on Finance. And monitor the process of this whole of what's going on with Family Care IRIS 2.0, and just regularly visiting that Family Care IRIS 2.0 website that DHS put together is a good way to do that. And keep an eye out for the public comment period, but certainly the Wisconsin Disability Association will keep people aware as well. Good thing to do is like the Wisconsin Disability Association on Facebook. We provide regular updates there, news items related to Family Care and IRIS, and also other news items. Please subscribe to the Wisconsin Disability Association email update. You can contact me, and my information is on the next page. Consider asking organizations and agencies with which you are connected to have a more comprehensive presentation by the Wisconsin Disability Association. As happened with the original Family Care and IRIS programs, I'd be more than happy to come and give a presentation to your group, so just let me know. But really the main message is, as it was when we transitioned to this current version of Family Care 1.0, is the train's kind of leaving the station. Changes need to be made to make sure that these programs are sustainable, and we need to have input. We need to be active in making sure that whatever comes about, whatever changes, maintain all the good things of the current program and maybe add a few more, while minimizing and hopefully eliminating any potential negative consequences in the program. So keep an eye on what's going on, and keep connected to advocacy groups, and keep connected to the Wisconsin Disability Association. Again, thank you very much for viewing this presentation.